For everyone with an interest in NASH, or more broadly fatty liver disease, Surf's Up. Season 4, Episode 38, Surfing the NASH Tsunami. A replay of July 2020 episode on nursing and patient education starts now.
Today, on Surfing the NASH Tsunami, a special reprise edition. This week, Surfing the NASH Tsunami will share a Vault episode from Season 1 on a subject that has new relevance today. Join liver wellness advocate Louise Campbell as she hosts an episode with our original team, including Louise, hepatology researcher and key opinion leader, Dr. Stephen Harrison, C-suite executive Dr. Peter Traber, and pricing and forecasting guru Roger Green, discussing the pivotal roles that liver nursing specialists, dietitians, and physician assistants play in the ongoing education and support of fatty liver patients. Today, on Surfing the NASH Tsunami.
Hi, this is Louise Campbell, co-host of the podcast, still known as Surfing the NASH Tsunami. While Roger and Jean are still on holiday, I'm delighted to host the replay of Season 1, Episode 16. This is one of our most overlooked episodes, mostly because it occurred the week after our transition to Buzzsprout, which means we had no contact with our early listeners in the week leading up to the episode, and the audience we'd built over our first 4 months needed to find us all over again, and you did well. We pick up this recording at the 11 minutes and 43 second mark in the podcast, which means this episode had the longest lead-in to content in the history of the podcast. The lead-in including, among other things, 2 minutes of ode music from our good friends Dr. Naima Corey, a tribute to Roger Williams, who had passed away the previous week, and a discussion of Virtual Easel, which took place 2 weeks after this episode. When we get to the episode itself, we hear Stephen Harrison, Peter Traber, Roger and me discussing the roles that nurses, dietitians and physicians' assistants play in the patient education. Roger leads off with the 4 questions, which we spend the next half an hour discussing. 3 years later, it's remarkable how well this episode holds up, and I hope you enjoy it.
Now to shift to today's topic. Today's topic, really, we're going to take a look at the pivotal role that nurses, dietitians, physicians' assistants, other allied health professionals play in treating patients. This really comes from 2 things we've been talking about some recently. One is this entire idea of wellness and illness, and that they're 2 very different paradigms in terms of how you look at patients and what you're trying to do for them and with them, and that they might produce different results. And the second, which I guess is kind of out of that paradigm question, is Stephen's comment about the smile curve, that you can get people to do really well for 3 months, but by 6 months they bounce back up. I've always believed that's an issue of how much behavioral training and what kind of psychological support goes in, and what psychological teaching goes into getting people through their events. That's why companies like Noom, for example, can be so successful, because that's the platform on which they're founded. When you look at organized healthcare, the role of being the intermediary, the person who teaches wellness and wellness styles and tries to coach patients to look differently at how they live their lives, tend to be nurses, dietitians, and physician assistants. We happen to be blessed to have a renowned one on our panel, Louise. And what I'd like to do right now, for starts, is just take a look at a few different questions, okay? And I've got 4, really. How much focus in what you do, and that part of the job, is on maintaining wellness versus preventing or self-treating illness, number 1. Number 2, how are the 2 concepts different in terms of what's presented to the patient and in the mind of the professional? Number 3, what are the keys in supporting and empowering patients to take better charge of their own wellness and to be more efficacious, not just for the 3 months before the other lip turns up, but in the long term, in terms of taking care of their own wellness. And then, let's stop there. We'll go through those for each of us. Then I'll come back and ask the 4th question to the group. Louise, you want to kick us off?
Absolutely. Happy to do that. I think if I look at how much focus is on maintaining wellness versus preventing and self-treating illness in what I do, obviously I've moved out of the NHS to take out diagnostics, to front load early diagnosis of liver disease. So I'm moving more into trying to maintain wellness and locate at a time point when we can try and prevent liver disease, because we have a long time to prevent it. Although I did within the NHS and within my previous roles, it was always about trying to maintain wellness and giving advice. It was usually at a far later stage where it is very difficult to change behaviour. It is very difficult difficult to engage if you only use blood markers. Utilizing things that engage patients helps change behavior. But I think very few people don't want to engage. There is this misnomer that people sometimes are hard to engage or hard to change behavior. It's about getting access to the level of information, I suppose. And a lot of patients with liver disease don't get it until they've been found. And as I've been an advocate for, we only find the few, we don't find the many. So I now have moved into trying to prevent and get better access. And a lot of patients can self-treat, particularly fatty liver disease, minor tweaks, minor changes. And I think the UK government today announced an obesity strategy, which I'd argue is now the first government internationally to announce a NAFLD and NASH strategy, because what they're targeting is high sugar drinks, advertising. And I think although there'll be a lot of people for it, there'll be a lot of people against it. Actually reducing and improving people's diet and exercise, we know, are the key factors to trying to change most of the outcomes of fatty liver disease. So it will make massive change even if we only implement it through marginal areas. We will watch cardiovascular risk drop. We will also watch an improvement in type 2 diabetes. And that one announcement by the British government today can trigger absolute tsunami of research in all areas where diet and liver disease can cross over. And I think long term, we will see it prevent deaths. And I think that's the advantage, whether people agree with it or disagree with it. The government has taken a stance as a result of COVID-19 and obesity. So I applaud that, but we've got a long way, and it's going to be delivered largely by allied health professionals in GP practices. So that answers question A, the first one for you.
So why don't you go on to questions B and C? How are the two concepts different? And what do you think are the keys to getting empowering patients to actually do that well?
I think patients, once they're engaged, do it very well, and it's speaking to them in their own language. I've spent a long time trying to educate people on cirrhosis who've had cirrhosis for 15 or 20 years, but because they didn't drink, they didn't think it was that type of cirrhosis. They see it written in letters, they don't engage with that term, and I think bringing it back to the basic concepts, using an analogy that somebody can visualize and understand really works. And it's how you present it, and every patient is different how you present it. And in the terms and the minds of professionals, I think we have to take that nurses come from a completely different angle. We are here to be the patient's advocate, and therefore we can disagree with our medical colleagues because actually we are there to protect the patient. And sometimes people think that nurses or allied professionals will just say no or put barriers in the way, but it is about a patient and it's protecting that right of the patient, and sometimes that trumps all. So there is a way that you can say it to the patients that absolutely engages them, but engages them in clinical trials, engages them in their care, and actually it engages them in their family's care. And I think that's an importance, because what we discuss with NASH Tsunami is not just about the individual, it's about everybody around that individual being able to help each other. Because one of the biggest reasons that weight loss is difficult is people aren't overly supportive, and it's very difficult if you're on your own. So it's not just obesity, because that's a highly stigmatized area and people eat for different reasons. So it is really important that we make the differences in the concepts, but that we absolutely engage the patient and empower them. And an empowered patient can move earth and heaven to achieve what they want, but they just need a guide sometimes and the right information at the right time. And that's usually with the patient in the room at the time of your intervention. And I think they want to know what happens and what they can do right now to make that change. So hopefully that covers those additional points.
Louise, I think that the things that you've said are right on point. And I'd like to make just a couple of observations from my practice of medicine and seeing how people are practicing medicine today. First of all, there are lots of people today involved in the care of patients. It wasn't like when I first came up through medicine where it might have been me and one nurse, and the nurse was spread very thin, as was I. But now we have many different ancillary healthcare professionals in nutrition, in behavior modification, nursing, lots of different areas. And one of the things that I think is critical for these systems to work is that they actually act as a team. And it means acknowledgement that each team member has certain skills and areas of expertise that are best for the team and best for the patient. And I still don't see as much teamwork in medicine as I think we need for something like changes in lifestyle and behavior. It would be very nice to have individual team members being experts in different areas, obviously dietary, behavior modification, and ensure that the team takes all that into account so that everybody is giving people the same message, but there's an individual there that is helping to guide the team. Because I think patients do get different messages from different allied healthcare professionals. I think that can be confusing to the patient. And I'm just wondering what you think about that. And then I have one other question for you. We talk about liver health, but there's so many other things that these teams of health professionals are dealing with, from hypertension, dyslipidemia, cardiovascular disease, osteoarthritis, obesity, etc. A lot of them are interrelated, but how do teams accomplish the kind of things we think they should for patients when there are so many different things that the team may have to do for different patients?
Your first point is absolutely excellent. I don't think we can at any stage care for patients and people unless we do act as a team. And I think what we're used to, and certainly within our liver practice when I was back in the NHS, then our hepatitis C would do that. We would have a massive multidisciplinary team every week, every fortnight, discussing the needs of those patients. And I think it was that coordination of care. But I'd like to see it a lot earlier in the healthcare timeline, because as we know, a lot of these conditions are diagnosed late. This should be at a GP and a primary care level. Every patient with obesity or the associated comorbid conditions, it would be great to have that multidisciplinary meeting about those patients. Now, we've got a strategy that's been published today that may well help that, because a lot of it is going to be delivered by GP practices. And I think having access to dietitians, we never had access to dietitians. It was a funding issue within the trust that the whole of the liver unit never had a dietitian, yet we know that financially getting patients out of hospital is great. When you've got a dietitian involved, it turns around patient care, it improves their outcomes, gets them out of hospital quicker. But it was a financial decision from the trust that we couldn't afford a liver dietitian, so we had to share one. So I think it is going to be very difficult in the way the healthcare system is set up within the UK to get dietitians at a community level for early stage obesity when a GP has to turn around and say, you just need to lose weight. We know that it's difficult for those patients to lose weight. So that entire coordination has to come up a little bit earlier. And I think that would lead on to the second point, where we get coordinated. We work as endocrinologists and diabetes specialists. We work within cardiovascular services. We're quite fragmented in the UK. Predominantly liver disease is seen as a liver condition for liver physicians. It is not as coordinated as has been described on this program before, where endocrinologists are consulted at the beginning in cardiac. So I'd like to see that move, because if that happens, GPs may well see this as more of a coordinated condition. And I think the new strategy driven by COVID and the mortality rate linked with obesity has driven us to now face that a lot of these conditions are connected. So hopefully we can get more care, but care can only be delivered at the best way through coordination and accepting that somebody else has those specialist skills, or even a theory or a suggestion that might actually help that patient. So hopefully that answers both of your questions, Peter.
I just think that healthcare systems, in different countries need some advice on this from, external sources, and maybe liver societies and fatty liver groups and so forth can help to provide some of the advice and impetus to push some of this forward. Because I've heard, having been around for a while, I've heard lots of the same kind of discussions going on, but less and less movement, I think, to the best system for handling patients and bringing particularly behavior modification types of regimens forward.
The most important thing Louise said to me in some ways was spawning research, because one of the things that I believe is under-researched within the medical profession per se is the most effective ways to identify patients and treat different patients in ways that are consistent with their own needs. If the opportunity now exists for the UK to do significant research on care coordination And the best way to get patients to respond in a wellness perspective, it's not going to happen tomorrow morning at 9 o'clock, but I would think that would start to move the focus in a different and much more constructive direction. I find that really hopeful.
Well, I find the comments Louise and Peter made to be very accurate. I guess what I want to take is a slightly different point of view, and that is the value of a passionate provider. I'll start off with two clinical scenarios that happened to me this week. The first one was a lady I've been following for a long time. She has autoimmune hepatitis and fatty liver overlap. She's been in remission for years now on low-dose CellCept. So really the struggle has been her fatty liver. And with COVID, I was unable to see her in person for about 6 months. She was going to her Weight Watchers support group until COVID shut that down. And for her, she's 70 years old, single, widow. That was her outreach. That was her social time as well. So she really kind of went into a funk after that and literally just told me, said, Doc, I just watched all the Breaking Bad episodes on Netflix and munched out on everything I could get my hands on. And she gained 16 pounds in that 6-month period. And, she admitted that part of it was just not being able to be seen and have that continued encouragement that always kind of kept her going. And for me, when I have discussions with patients who, for the very first time, I tell them often that, that if they don't work on their lifestyle and begin to reverse this, that bad things are going to happen, potentially. And I use the quote that sometimes later becomes never. I'll just put it off and do it later. And ultimately, they never get around to it. The other thing I tell them is the harder they work for something, the greater they'll feel when they achieve that accomplishment. And I've seen that over and over again. These patients who come in and they're losing weight, they lose 10 or 15 pounds. They're lighter on their feet. They're not as achy. Their joints don't hurt. Their right upper quadrant pain is gone. They want to keep They want to keep doing it. People are giving them positive comments. Their clothes are fitting better. And they come back and now they've lost 30 pounds and 40 pounds and 50. And I've got people that are now, losing 70, 80 pounds of weight. It's not overnight. It's over a year or two. And then the other patient was a brand new patient I saw who was referred to me for elevated liver enzymes. And that's all I had. I had no records. I had no labs. I said, why are you here? She goes, I don't know. The doc told me my liver was inflamed and I needed to see you. So what do? I order a fiber scan. Literally, I stop seeing clinic and I send her down the hall. She gets her fiber scan. She comes back and she has a CAP of 357 and a KPA of 5.7. So the first thing I told her was, good news, a great joy for you, because while you have fatty liver, and that's likely the explanation for your elevated liver enzymes, there's no significant fibrosis, at least on the scan I have today in front of me. And we're gonna go with that. We're gonna complete your biochemical and serological workup, make sure you don't have viral hepatitis, autoimmune, and other things. But the good news is that you can reverse this. And she said, how, doc? Tell me how to reverse this. I said, you need to modify your lifestyle. Tell me how. And we went through what I tell them. And I think at the end of the day, she walked out of there with this quote, Doctor, all I needed was you or somebody to get me motivated to get off my butt and do what I need to do. Now, not every patient's like that, but in that situation, we're hopeful that there will be positive results. And what I tell them is persistent and consistent. They need to persistently pursue their lifestyle modification, and they need to do it consistently. And there's some data that I want to share with you. There are two papers I found that I thought were apropos for this topic today. Number one is a needs assessment for weight management. And this was a paper published in the Mayo Clinic Proceedings back in 2018. And they did about 20,000 surveys in 5 healthcare systems in 11 states. They had about 2,400 responders. So it was actually a pretty good ratio. And what they found is that being younger, female, non-white, and single, and having some college education or less were all significantly associated with a higher BMI. And the most frequent weight loss barriers were food cravings and having a medical condition that limited physical activity. What's not on here? What's not on here is having somebody tell me I need to lose weight and exercise, right? So for me, it's a simple message, but we have to take the time to deliver the message. And when we deliver the message, it needs to be very, very simple. Again, a retired Army colonel, keep it simple, stupid has always been my mantra. And so we have to deliver the message in a way that can easily be taken home and relayed to the husband or the children or whoever to say, look, I've got to modify my life. I've got to start walking every evening. I've got to start carrying some hand weights. I've got to start doing some exercises, and I've got to limit processed carbs. I tell people no bread, rice, pasta, pizza, potatoes, or tortillas. That's simple. It's easy. Cut out the sodas, cut out the sugar-containing beverages, and let's see how you do. And when they come back, I reiterate that. There's some other data that's out there that says the more frequent visits we have with our patients, the greater the likelihood they're going to achieve weight loss success, or if not weight loss success, changing their lifestyle so that it actually affects a positive outcome. Here's a little sidebar. Maybe that's why the placebo response rates are higher or as high as they are, in addition to the heterogeneity of the biopsy read and that sort of thing. I suspect lifestyle modification is playing a role. So just to summarize, the other paper I wanted to highlight that I think is important is our patients often say, Doc, give me some proof that all this is working, that what I'm doing is going to lead to something positive. And there's another recent paper, I happen to be a part of this one, on physical activity measured objectively being associated with lower mortality in patients with fatty liver. And this was just published about a month ago in the Clinical Gastroenterology and Hepatology. And here we looked at a longitudinal analysis of the NHANES database from 03 to 06 and collected mortality data through December of 2015. And what we found is over a period of about 10 and a half years, increased duration of total physical activity was associated with reduced risk of death from any cause. And in a multivariate model, specifically among patients with fatty liver, an increased duration of moderate activity was associated with a lower risk of death from any cause in patients with fatty liver. So ultimately, longer total physical activity and even moderate physical activity are associated with lower all-cause and cardiovascular mortality in patients with fatty liver. And so I share that with them. So I give them positive reinforcement on their weight loss. I tell them that this is going to affect a positive outcome relative to these endpoints that I just mentioned. And I tell them the same message over and over again. And I do it with passion. I do it with compassion. And I'm persistent and I'm consistent in that delivery. And I think if you're in a situation where you don't have access to all these ancillaries, a nutritionist, an exercise physiologist, or other healthcare professionals that can help you frame a care plan for these patients, that hope's not lost. You can still achieve that if you're in an austere environment or you're on an island and you're by yourself and you have to manage these patients.
I just absolutely echo what Stephen says throughout that. It's about getting the right message to the right patient at the right time, and keeping it simple does work, because the more we complicate things, the more they get mixed messages. And I think we all have case histories where patients turn that round, and I think just keeping it simple, quick wins, doesn't have to be complicated, and using as much allied resources as we have is vital. Some patients will need way more than others, but it's having access to those. And sometimes the simple steps, the easy wins, just start the ball rolling, and patients get such reassurance and motivation from that. And going back to Stephen's smile curve, if you can keep them engaged, see them regularly enough, and I think telehealth will now make such a difference to that, is that these patients can be motivated extremely well and get great outcomes.
Louise, how often is often enough, do you think? You said if you see them often enough. Stephen made the same point. I'm wondering for both of you, how often do you think is often enough?
I think Stephen said it a while back. About 3 months, I think, was his definition of the smile curve. And I think I'd reiterate that. I think anybody who I have seen with fatty liver disease where you can make that change, if you see them within 3 months of doing that change, it works very well. I saw an 18-year-old who was a rugby player, front row, came in, had a FibroScan, kilopascals 13.9, fat cap was 339, and he went away. Often they don't at that age because they're immortal, wanted to keep his place in rugby. And what we did was he was going to university, eating your typical high-carb diet, student diet, pizzas, crisps, beers. And what he did, he turned healthy for the 5 days a week. And what he did was keep it to the weekends. When he came back 8 weeks later, having lost 7 kilos, he had a CAP score of 229. And what was most reassuring was that his kilopascals fell back into the normal. So what we were seeing was probably purely inflamed liver as a result of the fat. So it can be done, and you don't have to give up everything all of the time, and you can take a step back. For every 2 steps forward, you might take a step backwards, but getting that positive momentum helps people maintain it in some way. So for me, I'd like to see them at the beginning 3 monthly and then probably 6 monthly, because you pick up the ones who do change and it really motivates. You pick up the ones who don't and they start to take notice.
I think Louise is spot on. 3 months is a good time to get these people back and just say, hey, what are your challenges? What are your concerns? What are your wins? And reiterate what you told them before. They always have questions. 3 months. Hey, what about this? I had a lady one time said, I I did what you said. I quit eating French fries and potato chips, and I switched to sweet potatoes. And I said, whoa, okay, you did good there, but you switched to another potato. Yeah, but I heard sweet potatoes, they have lots of vitamins, and they're good for me. And that's true, but it's still a carb. We need to maybe not eat as many sweet potatoes either. And it was a little tweak like that really put her back on the point that she needed and continued to drive weight loss into the 6-month point. So it's always something little, and it's usually, interestingly enough, something little that derails these patients too. It's not that they don't want to do it, but something in life gets in the way, or they get confused about something and they don't have a way to follow up, and so they just bag.
I believe we really need to take advantage of what we've seen during this COVID crisis, and that is video chat appointments for patients, because it is expensive to go into the office each time, and I think we can do a lot more with video visits, and I would encourage people to look into that and utilize it.
Thanks, Peter. So let me come from a different perspective. As a guy who's lost 100 pounds over the course of his life, 50 once and probably 25 twice, and the second 25 was a year and a half ago, and that will stick because I'm getting too darn old to have to deal with trying to lose it again. I'm at an age where it wouldn't help me to have it. A couple of observations. First of all, patients frequently in those moments, one of the things they wrestle with is negative records or playbacks in their head. Can't do this, can't do that, whatever. Okay, and the negativity is the thing you're trying to overcome. The challenge to overcoming it is what happens after the day you blow it. And if you understand that it's just a day, you can get it back the next day, that's very different than if the message you send yourself is, oh, I blew my diet. Because then people just go hog wild. And I've done this both ways. I've gone hog wild earlier in my life, which is why I had to do it again. And then I figured out that it's just a day. Number two, and I'm intrigued by the 3-month comment, because it's not clear to me that on a 3-month pulse, that's enough to know. Some people, all you need to do is give them a steer once every 3 months, and they're so motivated to do the right thing or so fearful of how sick they are that they'll do it. But if you have no conditions per se, you're just 50 pounds overweight, which is kind of where I was. The motivation isn't about fear. The motivation is about knowing it's the right thing to do. And there, things like self-doubt, negative self-talk, and all that stuff comes more into play. During the time I was losing all that weight, I was actually talking to my doctor at that point, who was my friend, every other week. And I think if I'd been talking to him every 3 months, I wouldn't have made it. As it was, I mean, I gained half of it back eventually. So I wondered whether, A, the people that you lose, or the people that aren't, as Louise, you said, you get the ones who are really sick. The ones who aren't really sick yet, who could be dealt with before they ever get to that kind of urgency. There, I wonder whether it isn't more about frequent small adjustments and people who can help you hear the head voice. I know because I have friends who've been really successful Weight Watchers. I know because, as I mentioned, my wife works for Noom, and I know she tracks in with people once a week on little things, but usually once a week. I wonder, should healthcare be taking advantage of services that are organized around weekly or bi-weekly? Is that one of the things we should look to do with allied health professionals and telehealth? Or do we really think that's not something we need to do unless patients ask for it? Or is there a fourth option?
I think absolutely we should be taking use of it. These are very, very well established apps and networks for some of them. I think everywhere that we can look that can support a patient in any disease that makes a change, that makes a difference to their outcome. And yes, patients getting diagnosed with liver disease are the minor, and getting through the healthcare system is actually quite difficult. But I think, and that's obviously one of the reasons that we deliver FibroScans, trying to get them into primary care. But this becomes part of a great cost-saving initiative. If you can prevent fatty liver disease, if you can prevent the obesity area that causes fatty liver disease, you can reduce diabetes. With diabetes, you reduce bariatric surgery. With diabetes, you can reduce vascular surgery and amputations. You can go on and on about what can be reduced. So the ability to cost-save downstream by using any mechanism that patients find useful, and it has to be about the patient and what works for them. And Noom is a very good example of a highly developed app and group, but there are lots of little ones out there that can be just as helpful, and some people like groups, some people don't, so everybody's an individual. And I think to be able to use that strength to make cost savings to healthcare throughout by changing people's lifestyles and empowering them to do so is absolutely vital. So I'd say yes, use everything.
Well, actually, I want to go to a pre-question, and I want everyone's answer to be no more than a sentence, okay? And Peter, I'll start with you. 1 sentence answer. Is the healthcare system as constituted in the country you live in, different than Louise, able to deliver the level of wellness support that people need so they never get that sick in the first place? Is it able to deliver the level of wellness support people need when they are sick? Two-part question, one sentence.
The experience that I've had with this is leading two large healthcare systems at different times, the University of Pennsylvania and Baylor College of Medicine. And so I've seen it from the inside and from a leadership level, and I've also seen it from my own healthcare and my own family's healthcare. And I don't believe that our health system is structured or incented for wellness evaluation and training. In fact, it's why we see a proliferation of behavioral sites and so forth like Noom that Louise just mentioned that are outside of health systems, because health systems are not providing the kind of support people need. And that was a lot more than one sentence, Roger. I'm sorry.
Not a problem, Peter. It was quite precise and very good. Thank you. Okay, Stephen, can you do it in one sentence?
I agree with what Peter said.
That's funny. I was going to do it in 3 words, and they were what he said. So I think we're all in the same place on this. Louise, different perspective, UK, different country, different role.
I don't think, irrespective of coming from a different country, I absolutely agree with Peter. I don't think we can. We're a national health service, but we react to illness. We do not go out and prevent illness. So I agree with Peter. I don't think it matters about the countries at the moment.
Okay, great. So at some point in time in the future, not next week, we will bring on some people who represent the wellness companies and the wellness perspective, and maybe have a dialogue about what can we learn from them that we actually could bring into the treatment of patients in the realm we live in, or how can we work with them better. With that, let me go to final question. The one thing that surprised you most in what you heard today, I'll be the brave one. Louise's story about the rugby player really struck me. I'm the only non-medical professional on the panel, but I don't tend to think of people as going that quickly from a bad place to a good place because the problem is that simple. I'm also terribly impressed at an 18-year-old kid who didn't feel immortal and was able to do all that, and I suspect that you and the folks you're working with gave him some exceptional coaching. That's a story that's going to stick with me long after this podcast.
Peter, I would agree with that story, but it doesn't surprise me that much because personally, I found that because of a family history and because of being overweight, that my doctor told me, hey, Peter, you have diabetes now. The shock of that had me lose 40 pounds. And a number of years ago, I didn't have diabetes anymore. The problem is that without behavioral modification changes that were essential, I was motivated for a period of time, and then the weight creeped back over 5 years. So what we really need is a sustained effort in behavioral changes that I don't think we think about that much in the healthcare system. So, my comment to Louise was, follow that young man for a long period of time and see what happens.
Yeah, I'll just echo that and maybe say that we can talk to our patients about lifestyle change. We can put a whole team in place that addresses the needs of the patient. But there's a joke about psychiatrists that I'll use to end, and that is, how many psychiatrists does it take to change a light bulb? One, but the light bulb has to want to change. And I may have used that analogy before, but I think it's apropos. Or sometimes the hardest part for our patients is the 6 inches between their ears, and they have to want to change. It doesn't matter what we put in front of them. So I think that's important to remember also.
I think the thing that surprised me most is that not one of us thinks that we have a healthcare system that's suitable to do the wellness side, and I think that's a shame, but these are big, bulky systems that do need to change, and we do need to use other avenues.
I'm going to make one comment and then we'll go to close, which is that I think one of the differences between the wellness systems and the illness systems is that you have to spend your own money to get into the wellness system. And I think when people put their own money down, 2 things happen. It's a statement of commitment and it's a statement of investment. I'm not always a big fan of the idea that goes, if you don't have skin in the game, you're going to treat it less seriously, but in this case, I absolutely am. If it matters to you, you're going to pay for it. Not enough that it hurts, but enough that you're spending your own money to solve the problem. I think that actually helps people act better. Just my belief, coming from my capitalist side, Peter. That ends today's episode. I want to thank Stephen. I want to thank Peter. I want to particularly Louise, who had so much experience to share today, and that was great. As I say, come back next week. We're going to be talking about our easel coverage. We're going to be introducing you, or spoiler alert, reintroducing you to our new permanent surfer. And please go to the site, and if you're asked to give an email address, give it to us. We will send you links you can send to all your friends about how they can find their way to the show again. I think this is an episode people are going to want to hear. We've just got to make sure that we notify them. All right. Special thanks thanks to our new engineer, Mike Wilson, who is the guy who's going to make music an integral part of our show, maybe even Peter's if we can coax him out of his caution over this. The distribution folks at Buzzsprout, who took 15 episodes and moved them over in the span of 15 minutes and have been a delight to work with ever since. Social media master Eric Rounds, who's overseeing this entire transition. Our editor, Ellen Chara. Our new administrator, Paulette Ali, whose job is to make this whole thing run on time every week. And an extra thanks to you, particularly the subscribers who found your way here this week and can help us get back in touch with the people who weren't with us. We will be back next week with Exit 17. It'll be really good. We're going to talk about easel. We're going to introduce the surfer, and we're going to try to find music. So one last thought. If any of you who are listening in the liver community are musicians and you'd like us to pick up your music on the program, send a note and somewhere between 2 and 5 minutes of your stuff to surfingnash.com, and I'll get back to you and we'll talk about it. Until then, everybody have a great week. Stay safe. Surf on. We're done for today. Thanks.
And now for the Season 4, Episode 38 Business Report.
Roger will be back next week to host the Business Report. In the interim, here are a couple of brief notes.
At Surfing the NASH Tsunami, September is for conference coverages.
September will see the return of Paris NASH, and later in the month, SLD Summit, which we covered last year live when it was called the NAFL Summit. It does not look like Roger will make it to Europe for either event, but we still plan to cover them both. We'll have more details on this next week.
Listener numbers fell off a little last week, which is not surprising for a week of reruns.
After a remarkably robust first half of August, our overall listeners fell off the 10,000 download per month pace last week. Again, this is not surprising given that our episodes was a rerun.
Thanks, Luxembourg.
That said, we did have one surprise in the past week. For the last 7 days, Surfing the NASH Tsunami Podcasts.com's highest rated medical podcast in Luxembourg. This marks the first time in a while we've been number one anywhere, and I believe it's the first time we've ever been number one in a continental Western European country. It's always fun when this type of thing happens. And with that, I'm off. Thanks to Mike and Jake for pulling this episode together, and Roger for writing the opening and closing scripts, and overseeing the voiceovers on his down week. Next week, the core team will be back for another exciting episode. Until then, stay safe, surf on, and we'll see you on the podcast.
Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website.